Okay, so we're gonna hit all the big ones. Scleroderma. Forgot that one. Okay. So, again, when I prefaced this, the last time we met, some of your rheumatologic diseases are systemic. Okay, why? Because they involve connective tissues, and connective tissues are found everywhere in our bodies. Right, and so wherever there's connective tissue, these diseases can cause signs and symptoms. Right, and so sometimes the presentation is, from a clinical perspective, can be confusing. Okay, and so, you know, because what somebody presents, and there's a lot of overlap. There's a lot of overlap if you haven't noticed. Okay, and so ultimately, most of these have some kind of autoimmune component. It is an immune reaction, which means there's going to be destruction of tissues, okay, inflammatory changes, okay, and so because of the commonality of them being connective tissue diseases, that yes, there is some overlap, and so you can focus on what makes each one unique. Okay, it's like the anemias. Remember when we covered anemia, everything was like, okay, here are all the signs and symptoms of anemia. Every one of these disorders can present like that. So what makes this one different than that one? What makes hemolytic anemia different from iron deficiency anemia? Okay, and so you have to look at those details, and those should be your focal points, because that's what's going to tip you in one direction or the other. Okay. And yeah, some of the pathogenesis of this is multifactorial, much like even your cancers. Like somebody might have a genetic predisposition, but that doesn't mean that they're necessarily going to come down with it. It's kind of like you have the gene, however, you need that switch to turn on. And that switch is often something environmental, like a virus or some other infection or environmental chemical exposure, heavy metal, something. Okay. And so, you know, again, you know, this process, the pathogenesis of inflammation, becomes important even in these disorders. Remember, they're autoimmune, they're inflammatory. So keep in mind, with these kinds of disorders, when you have inflammation, it's going to lead to that very familiar, hopefully by this point, cascade of events. Okay. And potential. So with endothelial activation, okay, you can have your pro-inflammatory cytokines that they're going to activate some of your blood vessel endothelium. In rheumatoid arthritis, you're going to see angiogenesis that occurs, neovascularization that occurs within the synovium. And that's part of the process. It's got to feed. It's these vascular endothelial growth factors that get released from the inflammatory cell that stimulate these processes. You can have adhesion receptors that are going to allow white cells to then attach to the walls. They can then migrate into the tissues as macrophages, leading in, you know, and so when you have that kind of process, again, it takes the inflammation from circulating antibody into the walls of the blood vessels. Okay, and then that can trigger other changes, even clotting. Cytokines, they get released from your immune cells, okay, that they're going to create certain immune reactions, your complement pathway. When you get antibody binding to antigens, you're going to have that complement activation. You have myelomonocytic cells and other immune complexes, so you can have IgG binding with rheumatoid factor. Okay, which then is a molecule, is an antigen antibody complex that signals for your polymorphonuclear cells to then phagocytize it, which then leads to the destruction of those cells and the release of more cytokines. And this kind of rampant release, wherever this process is, wherever these antigens are going to stimulate some kind of immune reaction. Yes, and damage to the cells. So with cellular cytotoxicity, you're gonna have lymphocytes that get in, that are drawn to the areas. And these lymphocytes, they release like your interferons, some interleukins, etc. And they can also cause just damage to even healthy tissues. And so, and then being able to, some of the molecular mimicry that goes on, certain cells can actually alter their form and function to even support the response. And so, and sometimes it's going to target these tissues. So let's focus on rheumatoid arthritis, and since you had osteoarthritis. And one of the major, characteristics of osteoarthritis is that it's asymmetric, right? With rheumatoid arthritis, it's symmetric. It symmetrically involves the joint, okay? Think about it this way. If you have, it's not necessarily uneven loading or, undue pressure, so to speak. What it is, it's inflammation of the synovium. Now, where's that synovial covering? The whole joint, right? It's everything. That diarthroidal joint, you have a synovial covering that keeps the synovial fluid in. Okay, and so the whole synovium gets inflamed, which is why it becomes symmetric as opposed to asymmetric. Does that make sense to everyone? Okay, good. Okay. And so some general info about rheumatoid arthritis is that, yes, it involves connective tissues. So yes, it's going to involve your joints. Yes, it's going to involve other connective tissues in extra articular sites. So, yes, can you have vasculitis? Absolutely. Can you have episcleritis? Absolutely. Can you have pulmonary nodules? Yes. Can that affect the pericardium? Yes. It is a small percent of the population, but I guarantee that you will see patients with rheumatoid arthritis. And, it tends to affect females much more than males. And there is an elderly onset of rheumatoid arthritis that occurs even after the age of 65. Not as common, but it occurs. 70 to 80% of your patients, some might estimate it a little bit higher, but they will be what we call rheumatoid factor positive. So go back to your labs, and we talk about some of the labs with these rheumatologic conditions. And rheumatoid factor is a very specific factor, antigen, okay? Slash antibody, okay, or in this case, it's an antibody to an antigen, okay, and that will be present in the serum of patients with rheumatoid arthritis. So 70 to 80% will be RF positive, okay, and this particular antibody reacts to a specific fragment of IgG, okay, our own immunoglobulin, which triggers this immune response. Okay. Those who are RA positive tend to have more fulminant disease and the extra-articular manifestations. And so, you know, we'll see that more common. So with RF, with RA, we have the genetic predisposition as determined. If you do a family history, you're going to see that Aunt Joni and Uncle Lou and, you know, all these people have rheumatoid arthritis, or perhaps even another autoimmune disease like lupus or, you know, scleroderma or something. Specifically for RA, it's the locus for the gene is what they call the DRB1 locus, okay, which is when your HLA, your human leukocyte antigen, so on the surface of your white blood cells in the MHC class 2 molecules. So it is a DRB1 locus. What is it with ankylosing spondylitis?
B27.
What's your gene?
HLA B27.
HLA-B27, very good. Okay, so yes. These are things you should know. The environmental, like a virus, like I said, actually can initiate the reaction and the formation of antibody. Okay, and yes, it involves T helper cells, which are lymphocytes, which can release specific cytokines, especially tumor necrosis factor and interleukin-1, and then you form your antibody. Okay, so looking at that patho, what do you think are some of our treatment options? Come on.
Biologics.
Somebody's whispering it, but won't say it out loud.
UMABs, biologics, that group of meds.
Because what do? What are they? What class of drugs? You've learned this already.
Biologics, is that not the class of the drugs?
What, yeah, like.
It just like helps mediate the immune system and turn it off.
MOA.
Monoclonal antibody?
Not quite.
Okay.
TNF.
There you go, TNF inhibitors.
Oh,
Okay, see where, look,
it's painful for
seriously,
me.
look. If tumor necrosis factor is a major player in the inflammatory process, if we inhibit TNF, okay, then it, in theory, will do what? Decrease inflammation. Do you agree with that? Okay, so that's the target. Another class of drugs that's used is your leukotriene inhibitors or your interleukin-1 inhibitors specifically. Okay, so you're going to see that our drugs that we use target very specific causes of the inflammation in rheumatoid arthritis. The inflammation itself is what ultimately, over time, is going to lead to joint destruction and potentially even fusion of the joints, which we call ankylosis. So here's the suggested pathogenesis spelled out. And the next slide actually shows step by step kind of what happens in the, and I apologize for it being not in English, but this is what in the textbook online, and I complained to them, and they're like, "Oh, I didn't know that." So you fix it. Pardon me? Close enough. Close enough. You can kind of figure it out.
Yeah.
Pretty good.
Precious.
My point is that you gotta pair these two slides.
Muy caliente.
Pair the verbiage with the picture.
Oh,
All right?
muchas gracias.
You have a virus or an unknown stress that is going to stimulate this immune reaction and the release of these T lymphocytes. Up top on the left is your virus. Okay, it's going to get systemic within the body. It's gonna infiltrate into the synovium where it can start this immune reaction. You get the lymphocytes. Okay, and yes, the virus can actually itself stimulate synovial cells to proliferate. The lymphocytes, plasma cells, mast cells, you know, all of that inflammatory milieu that is going to then start to increase the vascularization as well as edema into the synovium. Okay? It leads to hypertrophy and hyperplasia. So as you start to see in the next picture here, you get proliferation of your synovial cells. 1 minute it works, 1 minute it doesn't. Okay, proliferation of your synovial cells on top. So up here, you get this kind of fibrous exudate within the synovial fluid. You see growth of your vessels. You see edema in the tissues. And again, when you have all this inflammatory cells in there and this inflammation, it's going to cause vasodilatation, allowing even more inflammatory cells to join the party. Then there can often be these development of lymphoid nodules, which are shown in this top right picture. They will develop. As that synovium proliferates and thickens and it starts to extend, it's going to extend in between the cartilage and the bone. It's going to find its way, essentially separating that cartilage and bone, creeping over in the synovium on the cap of the cartilage. And so it covers it. And when it does that, it deprives that cartilage from all of the healthy matrix of the synovial fluid. And so essentially it's going to lead to resorption of that cartilage. And once it gets resorbed, it's gone. And now you have bone on bone again, or yeah, that pannus in there, that thick synovium. And it just continues to migrate, and it will migrate into the bones, and it will lead to changes within the bony structure, and ultimately to the point that the joints become fused. As this synovium thickens, it can also extend into the ligaments and tendons that are attached to the joint. Okay? It can lead to destruction or disruption of these ligaments. It can alter their location, okay, and force them, say you're in like your swan neck deformity, right, as which is hyperextension and of the PIP and slight flexion of the DIP. And what happens is that inflamed synovium will displace your extensor tendon so that it forces it to the side, and then it allows it to kind of like mutate, and patients lose complete function in their fingers. Same with similar with boutonniere deformity. Okay, and so it can destroy the ligaments. We talked about it in clinical diagnostics, how C1, C2 is a site in the C-spine that rheumatoid arthritis likes to affect, okay? And so once it gets in there and this process takes place, it disrupts those ligaments that are attaching your axis and atlas, okay? And that's gonna increase the risk of subluxation or even dislocation and spinal cord dissection or transection. Okay, and so this whole process, okay? As you can see down here in this, it's showing this growing thickened synovium, this canis, that as it continues to grow, almost like a thing, like, yeah, really disgusting. Almost alien-like, and it's just gonna infiltrate, separate that cartilage from the bone, dissolve, that cartilage gets dissolved. And it can even extend into the support structures for the joint. Okay. Questions on that? Yes, go ahead. So that's maybe that one that they've been able to identify specifically. Usually they're not everything negative. Then it's like, maybe it's something else within the rheumatologic family. Okay. Yes, Ajay?
How does the joint use all of this synovium is in between?
Because once the, cartilage gets destroyed, okay, and you have all this inflammation, it's going to lead to calcium deposition, much like we've seen in ankylosing spondylitis. Right, and it will still lead to confusion.
Will the synovium continue to grow?
You know what, I don't know the answer to that. I don't know the answer to that. I know that this is part of the process, and whether the anus actually like disintegrates after a period of time or not, I don't know. Okay. All right, so if we look at some of the articular manifestations in your left column, this is joint pain and swelling at rest. This is a constant, it doesn't go away. It's not a use specific related kind of pain like you get with osteoarthritis. Okay. This is something that is an ongoing inflammation. And so it's going to be there at rest, and that stiffness is going to be there at rest. The stiffness takes even longer to go away than osteoarthritis. It tends to be symmetric, as I described, involving the whole synovial joint, and it tends to be polyarticular. So your patient presents and you have, oh yeah, I got this really painful swollen knee. Right? You've got to ask about other joints. Is it limited to one joint? Or do you have pain in other joints? Because that's going to help you differentiate between potentially a septic arthritis or a gouty arthritis and rheumatoid arthritis, and or even osteoarthritis with an effusion. The stiffness, again, it's going to last longer, usually 30, 60 minutes, not uncommon. So, and it can last longer than that. The joints involved, again, mostly your diaphragmatic joints, and so two bones. So, but especially involves your MCPs and PIPs. Down the road, it can involve the DIPs. Okay, so it's more kind of proximal to distal as opposed to distal to proximal, like you see with osteoarthritis. Yes, ligamentous laxity. Yes, tendinous stretching. And yes, because of the inflammation and the lack of use, muscle atrophy. Yes, joint deformities. Okay, so swan neck and boutonniere for rheumatoid. And for osteoarthritis, you have Heberden's nodes and Osler nodes. Pardon me? And they tend, the joints tend to deviate towards the ulnar side. This is really, really late in the disease process. So ulna's over here. If it's the hands, it's gonna deviate that way. If it's the feet, a lot of times you'll see that first toe, that great toe, and it will deviate the same direction towards the fibula. And they can have severe deformities of the great toe. Some of the extra-articular manifestations are listed here. And so, again, just think about this, a more systemic inflammatory reaction wherever these rheumatoid factor immunoglobulin complexes are, that it can create inflammatory changes. If it's in the blood vessels, it's gonna have a vasculitis, okay, which is just inflammation of the vessel walls. Not just, but it is. And if it's in the eye, it can be anything from a keratoconjunctivitis to episcleritis to uveitis. What part of the eye is affected? You can see pulmonary nodules, as I said. You can have nodules, subcutaneous nodules. They're often near the joint or around some of your tendinous structures. You can have a thrombocytosis or even anemia of chronic disease. And then there can also be a specific syndrome called Felty syndrome, where they have rheumatoid arthritis, plus an enlarged spleen, plus a leukopenia. And more specifically, a neutropenia. Diagrammatically, shows you some of the disorders, some of the manifestations that you can see. Early in the stages, images are not going to show much as far as your joints go. You won't see necessarily the cartilage erosion. You might see an effusion, but you can palpate an effusion. What's your technique for palpating of joint effusion? Let's say of the knee. Ashley's doing it with her hands.
Like the milk thing.
Yeah, you milk it down. What's it called?
Allotment.
Allotment. Yep. Okay.
Allotment and there's one more.
There's one more, I think it's right.
All right, so
Is it?
This-
Doesn't start with.
this image actually shows one of the nodules on the digit. And that's a rheumatoid nodule. It's subcutaneous, very nodular. The little erythematous. And if you biopsy that, this is what you would see next to it, histologic, with a central area of necrosis. And all of those little purple dots in there are all of your white blood cells, macrophages, and it just shows all the inflammation surrounding within this nodule. Now, with all of that inflammation, what would you expect your SED rate to be? Right. And in rheumatoid arthritis, interestingly, the higher the SED rate, the more profound the inflammation. It correlates linearly. And so whenever the diagnosis of rheumatoid arthritis and med, but yes, they can be RF positive or RF negative. Yes, false positives and false negatives exist. So you often have to do this whole workup that involves workup for other rheumatologic entities. There is the anti-cyclic citrullonated peptide or anti-CCP autoantibodies. You can run a test for that. If it's positive, which it's not positive in a lot, but if it is positive, it is much more specific for rheumatoid arthritis. And however, it's not predictive of your disease progression. Now, your RF factor is predictive, and the higher your SED rate is, often the more inflammation is there. But you would add an anti-CCP or, do an add-on test or do another set of labs. You can, a lot of times, depending on how your patient presents, you've got to tap that knee and roll out a septic joint. And that joint fluid should be able to point you in one direction or the other. Okay, and so it does tend to be cloudy. There are leukocytes present. Okay, but it's not going to be to the same degree as a hot infected knee with Staph aureus. Okay, what's the gram stain going to show? Any bugs in rheumatoid? Nope. Okay, so you're not going to see gram positive oxide or gram negative. So you've got to do that gram stain and culture. What other tests can you do with your synovial fluid? Simple tests. What can you ask for when you send your fluid? So we're doing gram stain, culture. What else are you looking for?
Light microscopy,
Pardon me?
like the
So
light
cell
microscopy,
count and differential. And what else?
the light microscopy for like.
So crystals, okay, so you want to look for crystals. What else? Pardon me? Maybe not a biopsy yet, but potentially down the road. We're just on synovial fluid right now. Well, you could do serology if you're thinking what? Like like Lyme disease or something like that, you could. These are basic.
Protein.
Protein, glucose. Okay. Protein and glucose. If it's bacterial, what's your glucose gonna do? Go down. Okay, because it's a food source. Okay, what about your protein? Gonna go what?
Normal or up.
Right, because it tends to be exudative. Well, the protein can potentially be elevated in rheumatoid. Is it exudative? Yeah. So it might be up a little bit, yes. Right? Are you having tissue destruction? Yes. So. And then, of course, as far as your treatment, from a clin medicine perspective, your goals are to minimize joint dysfunction and maximize function in your patient. And so if you just look at your treatment options, again, as I said, your first line is still methotrexate. From a board perspective, I'll just tell you this, it's still methotrexate. Okay? Methotrexate, unless the patient's allergic or they've failed therapy already. Okay, that and Dr. Noel will tell you the same thing. Okay. However, look at your other drugs and your other DMARDs. You have biologic response modifiers, you have tumor necrosis factor inhibitors. These are the big ones that are being used now. And you have IL-1 inhibitors a little further down the road. Okay, and so they're targeting very specific parts of the inflammation. Okay. And they're they're looking into, there is some investigation now into even another inflammatory pathway for rheumatoid arthritis. So stay tuned. Things will probably change, maybe even before you graduate. All right, questions on rheumatoid arthritis? The RB1 locus, it's symmetric, it's synovial inflammation, it's white cells that essentially destroy the joint, all the connective tissues. All right. Moving on to lupus. Lupus is very, very interesting. It's a terrible debilitating disease, but it runs an entire spectrum. And it is chronic, it is an inflammatory process, and yes, it can involve any organ system. Over 1.5 million Americans are diagnosed with lupus. It affects women significantly more than males. 85% of your lupus patients are female. And yes, it affects Blacks disproportionately. More so than Hispanics and more so than Asians, with Caucasians being less likely. Okay, it tends to be a disease of younger adults, and with most cases occurring between the ages of 15 and 44 years of age. So it can have a significant impact on life if it's not addressed early. There are 4 subcategories. The most common one we abbreviate as SLE, is your systemic lupus erythematosus. And that is your most common. There is a cutaneous lupus. This is less common, but a small percentage of these patients will progress to full-blown systemic lupus. There is a drug-induced lupus. If you stop the drug, all the lupus syndrome symptoms and signs go away. Okay, drugs known to induce this lupus syndrome are hydralazine, procainamide, and isoniazid. There's also a neonatal lupus, but this is typically from maternal antibodies. And so the baby may actually be born or have cutaneous manifestations that then resolve after 6 months because of the waning of mom's antibodies. The exact cause, totally unknown, definitely multifactorial, and genetic, with sex playing a key role, obviously, with 85% being female. Now, this one's a little bit different in that instead of T cells, T lymphocytes, this is B cell hyperreactivity and an increased production of antibodies against both self and non-self antigens. Okay, so it's B cells. You know, B cells are responsible for antibody production. B cells become your plasma cells, produce your immunoglobulins. Okay, and so it's just kind of haywire, out of control antigen production. And so depending on how prominent it is and how many antigens it targets is going to kind of depend or determine how your patient is affected. And so if you think about it, like some of these antibodies are against nuclear, the nucleus of the cell. So you have anti-nuclear antibodies, you have anti-DNA antibodies, you have anti-phospholipid antibodies, you have anti-Smith antibodies. Okay, so you have all these different antibodies that can attack different parts of the cell itself. And so depending on which ones the patient has, again, that's gonna determine how fulminant or widespread or different tissues their disease is. Okay, there's antibodies against red cells, there's antibodies against white cells, there's antibodies against platelets, there's antibodies against clotting factors and complement. So you can see it can be quite a spectrum of disease. Okay. So as far as your factors, the multi-factors, genetic, sex/hormonal, immunologic, and environmental. If you break it down into your immunologic and environmental, right, so your genes from an immunologic, your genes linked to HLA, DR, and DQ loci, okay, as opposed to HLA, DRB1s. These are going to be HLA, DR, and DQ loci on your white blood cells. Environmental, UV light, chemicals, including drugs and hair dyes, some foods, some infectious agents. So quite a few. We don't always know. When you look at the actual patho of it, okay, you have this maybe genetic predisposition. Then there's some type of exposure. They sound familiar? It's a similar pattern, just different pathway. Okay, and yes, whatever the immune reaction is, it can lead to cellular damage in the epidermis, especially when UV light hits it. So what's the classic lupus presentation? Butterfly rash, okay, on the malar area of the face, bridging the nose, okay? But they can also have it any sun-exposed surfaces. So when you examine your patient, it's so important to make sure that they are in a gown so that you can examine full skin and look, is this a sun-exposed area or is this not a sun-exposed area? So when this exposure hits, it releases a bunch of antigen. And some of that antigen will get into the skin where the immune complexes occur. They'll form. And then sometimes some of that antigen, the antibody, those immune complexes will be deposited within the different layers. Okay, and that can lead to changes as well. So again, this is a multi-organ system disease. So the presentation and manifestations are very broad, can affect the musculoskeletal system so that, yes, they can have arthritis. Yes, can involve the skin, so they can have dermatitis. It can involve the cardiovascular system. Right on down the line, pretty much every system in the body. It can be acute or insidious in onset. Typically, it follows a period of exacerbations and remissions. Okay, but overall, the trajectory tends to be downhill. Okay, and with worsening and worsening function by the patient after the more exacerbations they have. The most common sign and symptom is the arthralgias and arthritis. And that's often what patients will present with, although I've seen them present with a uveitis. And tends to be symmetric, which is why sometimes there's a lot of overlap with, and you have to discern whether it's rheumatoid arthritis or lupus, and because of this symmetric polyarthralgias. as far as your skin, these can be acute, subacute, chronic. Okay, and they vary multiple different presentations. Okay, and so, you know, you just kind of have to keep a broader perspective when you see somebody come in with a crash. As far as the kidneys, about 50% end up having kidney involvement. I trying to remember, I think it's the anti-Smith. People who are anti-Smith, antibody positive tend to have more of the renal involvement. And so even the kidney itself, there are multiple forms of involvement. So it can involve the mesangium of the kidney as the support tissue with your immune cells. It can involve, it can be focal or focal proliferative, diffuse proliferative, it can be membranous, they can also have an interstitial nephritis, nephrotic syndrome. So they can present in multiple ways. And so if you're evaluating your patient, you've always got to see and determine, get your baseline blood work, look at your glomerular filtration rates, make sure that they're viewing creatinine, all that is within normal. If you start to see alterations in their GFR, this is when you want to refer them to a nephrologist and let the nephrologist make the determination as to at what point do we biopsy to determine what is going on with this kidney, okay, and what type it is, if it's even related to the lupus. Okay, because these patients are often on many medications and you just kind of have to need to know. And so the only way to really tell what's going on is to get that biopsy. From a pulmonary involvement standpoint, again, broad perspective, it can be effusions, pleuritis, pneumonitis, pulmonary hemorrhages, right on down the line. Okay. And the cardiac, think connective tissue, that your pericarditis, myocarditis. Okay. As far as your central nervous system, if the vascular beds are involved and it's a vasculitis, it can lead to strokes and hemorrhage within the brain. Nerve cell destruction can occur as a result of antibody mediated attacks on the neurons. With antiphospholipid antibody, you can have ischemic strokes. Seizures are possible. Even acute psychosis and cognitive changes and mood changes, where patients can actually present with a lupus cerebritis. And they're acutely psychotic or having acute episodes, and it's all due to lupus. And we treat it, try to get it under control with high dose steroids, pulse steroids, and then try to get the patient on the correct medication. Yeah.
Going back to you, if you have more melanin in that's needing protection, then how do they get more susceptible? How does that?
Okay, so tell me about how is melanin UV protective and how does it work? Marijuana.
I don't.
Yeah, I can get contact high.
Melanin is a dark pigment. You know about dark pigment, it's kind of like. Okay, so dark absorbs the light. White reflects the light. So the melanin is actually absorbing that UV light into the skin. Think about it that way. It's protected
Go now,
against
smell it.
skin cancers. However, it's absorbing that UV light. And it's bringing it in, which then can add to the trigger of these antibody antigen complexes. All right, hematologically, they can even have this hemolytic anemia. If they have antigen that is binding to the surface of the red blood cell, or antibody binding to an antigen on the red blood cell, that can essentially create the same kind of process you see with IgN, like hemolytic anemia or IgG hemolytic anemia. Leukopenia, lymphopenia, thrombocytopenia, the whole 9 yards. And then there's a specific discoid lupus that has skin plaques. A little bit different than your psoriasis. However, you will see it's very well demarcated lesions. They, again, pictorially, this is where you're gonna find signs and symptoms of lupus. Remember, it is B cell driven. B cells produce antibody. There are your two loci that have been identified. And so as far as diagnosis and treatment from a clinical perspective, it's, you've got to run the whole kind of rheumatologic workshop and figure out which one is it, okay? Yeah, I was right, so I thought I remembered correctly about the anti-Smith. If you see anti-Smith, you've got to really, really look for that renal involvement, okay? And they tend to have poor outcomes earlier because of the kidney involvement. As far as you learned in clinical diagnostics, your ANA is non-specific, but 95% of your untreated lupus patients will be positive. Yes, there are still false positives. It's non-specific. The anti-DNA and anti-double-stranded DNA is more specific. The anti-Smith, if they're anti-Smith positive, is more associated with the lupus nephritis. So, and so they've got to manage both acute and chronic. And again, it's preserving organ function is your ultimate goal. So, yes, Sheila.
Oh, I have a question about why is the ANA positive and only the untreated? Or is it just saying, that the more? Like, I don't, is that just saying that it was more of the untreated who had a positive ANA?
So if you're evaluating a patient who comes in for the first time, okay? Because ANA is non-specific, because it can be positive in a whole host of other conditions as well. So what you're saying is like, okay, your patient has never been treated for lupus or rheumatoid or whatever, any of these diseases, then, 95% of your lupus patients will be ANA positive. Remember, your titers can go up and down, and we look at those titers. And so that titer can fluctuate with the course of disease. And does anybody remember what we said our cutoff was for what we really considered a positive ANA? 1 to what? 160. Okay, 1 to 160. So all those dilutions. As patients get treated, that titer will often come down. So it might be up in the 600s, but if they're treated, it might come down to 1 to 80. And at that point, is it truly considered a positive when we say our cutoff is really 1 to 160? Those titers will fluctuate with the course of disease. Okay?
Yeah.
It's not like positive or negative. I mean, you could be 1 to 4, 1 to 8, 1 to 16, 1 to 32, 1 to 64. Okay? Those are your doubling of your titers. And so the cutoff really is 1 to 160. For what they consider it to be truly positive. We treat, it drops. Have I lost you?
No, I guess you're saying, I guess that I'm just confused now, because like, just because you have treated lupus, like, you still are AMA, you still have an AMA.
Correct, correct. But what we're just saying is this, what this is saying. Again, is if you, at that point, you already know that your patient's lupus positive. I'm talking about first evaluation. If they've never been treated. Okay, 95% of the people will be AMA positive. But even with that, you can have false positives. And false negatives. So you run your panel. Can your patients with rheumatoid be ANA positive? Can you have both? Yeah, you can have both disease processes. I saw a hand in my peripheral vision. No, making stuff up. Not when you do their hair.
I got it.
Wow. I like it. No, I like it. Just different. Like, there's a guy in the back. Got rid of the long locks and
Yeah, Peter was collecting of it.
It's stunned.
I like it.
Thanks.
All right. All right, questions on the patho of lupus? Now, I'm not gonna ask you statistics. I'm not gonna ask you statistics, so don't get too caught up in that. I mean, from a fundamental standpoint, I don't know what they're gonna ask, but from my standpoint, I'm focused on the patho.
Real?
Right, systemic, well, why don't you take a break? We've been at this for an hour. I'll pick it up at quarter up. You don't think?
Good answer. Senioritis.
Arthritis, so what's the sclerosis part? Thickening, yeah, like thickening, dense, fibrous, kind of. That's exactly what this is, and it's systemic, okay? Or it's called systemic sclerosis or scleroderma. So where is a lot of this occurring?
Skin.
Yeah, exactly. Okay, break it down to what you know. Okay, I went to school, my undergrad, there was a young woman in my undergrad, class who had scleroderma. And she was like always covered in all these emoluments that have all this, like, they had the funkiest smell all the time. And her face, like, you know, it was so horrible. It was like, she was my age and she looked like she was 30. You know, I'm talking, I was 17 when I went to college, you know, so it was just pretty. And I started when I was 17. Anyway. So, and yes, the tightening of the face and the tightening of everything. So, you know, this is autoimmune, okay? And this has to do with excess collagen deposition. Okay, within the skin, as well as your other connective tissues. So it's Systemic sclerosis, so this collagen is going to be like in everything, thickening and make, yes. Pardon?
You didn't change this.
It didn't change for me.
Thank you.
Okay, there we go. All right, so, thank you for that. Let me know. So yes. The skin thickening is via fibrosis. But think about the other tissues, and when you have dense fibrous collagen that gets into your other organ systems, what's it going to do? How's it going to affect the lungs? Make them less compliant. It's not, yes, fibrosis, like interstitial fibrosis, gonna make them less compliant. Okay, and they're not gonna be able to expand. And you have it in the GI tract. It's gonna slow peristalsis. Okay, it's in the heart. It can affect the heart's ability to expand, contract. It can lead to sclerotic vessels, your sclerotic coronaries, etc. The kidneys. Okay. And when you get all this fibrosis in the skin, some of those subdermal structures like fascia, your tendons, all these vessels, they become fixed and they can actually become like almost, they get obliterated. So distally is gonna be more problematic to the point where these people actually end up having like essentially necrotic fingertips from all the compression. Okay, the furthest it is, the denser those tissues, the more compression on those blood vessels, the less blood flow, more ischemia, and they lose their digits. Much more common in females than males. 4-to-1 ratio, tends to be an age of disease of younger people, so 25 to 50. So we don't, it's not very well understood. And the autoantibodies correlated with HLA-DQB1. So again, autoantibodies with that gene locus. And there tend to be abnormalities of both humoral and cellular immune system. So both the B cell line and the T cell lines. Now, there is a difference between the ABCD Crest syndrome and then your diffuse generalized scleroderma. So looking at the manifestations, okay, with systemic scleroderma, generalized scleroderma, tends to be more involving the skin. However, you can have very early onset of your organs. Ultimately, you get that stone face because all the ligaments and all those little structures in the subcutaneous region become fixed, so you can no longer contract. They can't smile. They can't have expressions. Okay, it's similar to even Parkinsonism. Okay, down the road, when they get the stone faces, they have trouble swallowing the esophagus. They have malabsorption issues. They have respiratory failure and, dyspnea. If they have renal vascular involvement, they can end up with malignant hypertension. They can end up with renal failure. They can end up with all kinds of cardiac abnormalities, including heart blocks. Now, the ABC Crest syndrome, Crest is, as you probably already learned in ClinMed, stands for calcinosis, Raynaud's, esophagitis, sclerodactyly, which is the finger thing that I was telling you about, and then telangiectasias. Okay, but there's also the ABCD part of it, and you only need 4 of those to diagnose Crest syndrome, scleroderma. So Crest is easier to diagnose than the systemic generalized scleroderma. There are autoantibodies. There's an SCL70 that's only present in about 60% of the cases of generalized scleroderma. But you also have to rule out some of your other connective tissue diseases because of, you know, again, all this overlap. You're gonna be running these panels. If you're suspecting scleroderma, you can add on that autoantibody SCL70. Just because it's negative, it doesn't mean that the patient doesn't have it, so. And we don't have, unfortunately, we don't have a lot in the way of treating these patients. We try to target, but a lot of times they're on, you know, it's more supportive care than anything. And, if they have early organ involvement, clearly that's gonna, you know, bode poorly for prognostics, and they don't live very long. So, again, not well understood. The stone faces, kind of the inability to really like smile or frown. You can see in the hands, you can see the Raynaud's start, you can see some of these Raynaud's in the thumb, you can see the white kind of area that's not pinking up. I don't know if you can make that out very well. But you can see over here in that thumb, you can see some of the skin manifestations. You can see some of the strange rashes. You've got joint involvement around the knees. Look at the ankles. Look at the white kind of in the feet. And so that's all, that white area is all showing vascular compromise. So if you look down here, this kind of ruber area, and then you got this white, kind of similar around the knees. But again, from a pathophysiologic standpoint, I stick to the fact that this is autoantibodies with HLA-DQB1, and both humoral and cellular immune systems are involved. All right, polymyositis and dermatomyositis. Poly muscles involve inflammation. So dermatomyositis, skin plus muscle inflammation. So these two are very similar. One involves the skin, one doesn't. Okay. Both involve muscles. The dermato involves the muscles and the skin. So you're gonna have skin lesions. That's what you look for to discern one from the other. Okay, and again, multifactorial pathogenesis, and this involves both acquired or humoral and cellular immunity. And the muscles that are involved initially are often your proximal muscles, so your shoulder girdle, your hip girdle, okay? And so they have weakness, they can't hold their arms up for any extended period of time. They fatigue very quickly and they're very weak in those shoulder girdle and hip girdle muscles. Okay, they can have occasional pain in the muscles as well as tenderness on palpation, but it's symmetric and proximal muscle weakness. If there is systemic involvement, as you've seen with other rheumatologic conditions, you know, it significantly affected morbidity and mortality. So poorer outcomes in those with other organ system involvement. Mainstay of treatment right now is steroids. And as you know, steroids have their own, they have their own drawbacks. So for poly, if you look at the pathophys on this, there is a little bit of a difference in that the inflammation is around individual muscle fibers. Okay, and the infiltrates are T cell, more CD8 than CD4. Okay, T cell and macrophages. Compare that to dermatomyositis, where the atrophy is around the peripheral bundles, not the fibers themselves, but around the bundles within the actual muscle. And it's predominantly B cell as opposed to T cell. And the T cells that are there are predominantly CD4s as opposed to CD8s. You'll see that infiltrate more so in the space surrounding the muscle fascicles. So structurally, instead of within the muscle fibers and damaging the cells themselves, the muscle cells, it's surrounding these little bundles and in that perifascicular space. And what happens, it also in the capillaries, and it activates your complement cascade in the dermatomyositis. So there is a difference between these two, although they share a lot of commonality. And so because in polymyositis, it's involving the muscle cells, okay, proper within these fibers, they infiltrate the fibers into the cells, and then the T cells, those CD8 cells, will release their cytokines, which then essentially degrades that particular muscle cell. It will kill it, causing, and so it'll destroy that muscle cell. And this is not apoptosis, it's not programmed cell death. And so it's going to trigger this whole inflammatory cascade. In dermatomyositis, because it involves the fascicles, it's around, it's in the capillaries, and you get this complement activation that's going to trigger this inflammatory response. Some people, some theorists at this point seem to think that a very small vessel vasculitis occurs first. And so these B cells and CD4 T cells, okay, are going to trigger damage to the vasculature, these very small vessels that are feeding these muscle bundles. Okay, and it's going to really cause ischemia, which then is going to again lead to an inflammatory response after they become more beyond the point of no return, essentially. But that ischemia itself will cause weakness. So a little bit of difference is there, and you should be able to differentiate the patho of one from the other. And the pictures on the top show normal muscle and polymyositis, where you see the inflammatory cells invading even into the muscle cells, into the fibers, into the muscle cells themselves. I don't have a picture of them. And this just shows it, kind of the patho of the damage with the polymyositis. Some of the clinical manifestations tend to occur weeks to months, so it's kind of more of a subacute to chronic presentation with that proximal girdle weakness as the kind of hallmark symptom. Sometimes they'll have muscle aches with it, but it gets to the point where even standing up from a chair, from the toilet, trying to put clothes on over your head become very, difficult normal functions. And in dermatomyositis, the skin itself becomes extremely painful and like a burning sensation. And it'll actually start to crack and ulcerate. And so these are some of the classic rashes that you'll see and changes that you'll see with dermatomyositis. So add that to the proximal muscle weakness. Any questions? All right, Sjogren's. Sjogren's syndrome. Another autoimmune. In this particular case, it attacks the exocrine glands, okay, primarily. So this is, they tend to have dry eyes, dry mouth. They can't salivate. Very difficult to, it affects their ability to swallow. The dry eyes, they end up, because of lack of moisture production, which every time you blink, you're lubricating your eyes, they dry out, they burn, and then they get blurry. The inflammation that results is what we call keratoconjunctivitis sicca. It affects women much more than men, usually in the 4th or 5th decades, 30s and 40s. It can be primary disease or it can be secondary to other autoimmune diseases. And so the autoantibodies are very specific and we can measure them. And yes, there are certain viruses that have been implicated as an environmental agent that triggers this autoimmune response. Okay, including Epstein-Barr, cytomegalovirus, hepatitis C, HIV, Coxsackie virus. And so commonly, these all can infect the salivary glands. So there are two kinds of pathways that occur in Sjogren's. And so you have the autoimmunity, okay, of the skin, okay, the skin cells, the epithelial cells, okay, that actually will form an immune response, okay, against specific antigens. These are Fodrin, Law, and Rho. There are some other antigens within your specialized glandular epithelial cells. And these are often your type 3 muscarinic ACH receptors. And so, once you get this autoimmunity going, usually as a result of a viral infection or a viral, viral exposure, the exocrine tissues will then become infiltrated with all of these cytotoxic lymphocytes. And that will, as they release their cytokines, it's going to induce death of the cells that line the ducts. And then they no longer function. So essentially, it's an autoimmune destruction of the glands and or the ducts leading to the glands. And so it's kind of like it's two-stage pathway that occurs. And so yeah, so when they manifest these patients as, and again, the infection can be a while back that and then, they just figure, okay, well, I'm getting over this, but then these symptoms not just persist, but then worsen. So it's not always tied specifically to an acute infection where this happens very rapidly. And, you know, a lot of these patients, they'll just get tired of it and say, my eyes are just so dry and they burn, and then they'll complain about, you know, the lack of saliva, right? And yeah, saliva helps to emulsify your foods. It starts the initial digestion process of breaking down your starches. And it also has some, you know, enzymatic activity to keep down bacterial counts in your mouth. So without that extra saliva, these patients can develop more dental caries. They don't have as much flavor when they're eating, and it makes it very difficult to eat. So in Sjogren's, the main complaints tend to be the eyes and the mouth. However, it can also, because it affects the exocrine organs, it can also affect the exocrine in the skin. These patients have very dry skin. It can affect exocrine and function in the vaginal area. So painful intercourse, dyspnea, technical name, and then even hoarseness. So it can affect vocalization. With the immune response, just like in some of the other rheumatologic diseases, they can actually feel some of these kind of like the overall impact of ongoing inflammation, which is fatigue, potentially low-grade fevers, body aches. So all of those can be part of it. So it can also present as a, you know, kind of a, you know, non-specific finding. Other organs can be affected with Sjogren's, including the kidney, livers, and lung, joints. And so again, here's where if the joints are affected, how do you differentiate it? And so you're going to be running kind of your whole panel of tests. And there is, if somebody has Sjogren's, there is a high association with autoimmune thyroid disease. Right? Now, which comes first? Patients may have an autoimmune thyroid disease and then present later with Sjogren's like symptoms, or they have Sjogren's and then develop an autoimmune thyroid disease. So you just kind of have to keep it in mind with your thyroid patients or Sjogren's patients. Like there's also a high risk for cutaneous vasculitis. It's very difficult to manage these patients, although they do have some newer treatments, which are helping significantly. At one point, we only had like artificial tears and to artificially lubricate the eyes and cover the eyes with glasses to protect them from air drying out the mucous membrane, hydrating, using sialagogues kind of thing, like just keeping the mouth moist with lozenges and things like that, artificial saliva. But now we do have some systemic therapies, which Dr. Noel will go over, which can be very, very helpful. But yes, you can see the redness in the eyes as a result of just being dry and not having that lubrication, and the mouth. Fibromyalgia. You know, fibromyalgia is not a wastebasket diagnosis as it used to be thought of. Anything that they couldn't pinpoint to say it's this or it's that, oh, you got fibromyalgia. Okay. And so fibromyalgia got a really bad name because it was kind of a wastebasket diagnosis. And these patients often doctor shop because they never got an answer to what their problem was. And they would come in and they'd have a list of medications this long, and nobody wanted to deal with them. Nobody. Nothing really relieves the pain. If you started them on opioids, guess what happens? Yeah, pretty much. Dependence, tolerance, and addiction. Yeah, and it creates a vicious cycle because they need increasing doses over time because of tolerance issues. And so, narcotics aren't necessarily the right path. And so a lot's been done, and there's a huge organization that out there that's kind of like really pushing that fibromyalgia is a very real disease process. It is now considered a central pain disorder. So it's central pain, but where are they actually experiencing the pain? Where they have pain? You covered it in the fundamental. Where do they have pain? Everywhere, right? It's everywhere. It's diffuse pain. It's pain above the waist. It's pain below the waist. It's pain in the extremities. It's pain in the torso. It's pain everywhere. Okay, and so the disorder is considered central pain because it is it's a disorder of pain processing in the brain. Remember that pain is a subjective experience. Okay, what else does it involve? We talked about this at the beginning of the semester. I could revisit it. Pardon me? Cultural. Perceptions, personal perceptions, okay? Emotions, correct. Okay, so there's a lot of input that makes up a patient's experience of pain. Pain is subjective. You all have seen photo of image x-ray of my foot when I broke it, at least, okay? Would you believe I only took a week? Yeah. I went into the urgent care and told them I broke my foot, and they were like, thought I was a drug seeker, really did. I swear they did. Now, how do you know you broke your foot? I know, I fell, and it's broken. And I'm just like, they're looking at me like, okay, have a seat. And then the nurse takes me back and she's like, so tell me how you broke your foot. Or what happened? Like, well, this is what happened. I fell and this is how I knew I broke my foot. And then she was like, oh, okay. And then she's like, can I take a look? I'm like, yeah, go ahead. She's like, oh, well, there is a bruise there. I'm like, it's broken. It's like, I'm like, okay, well, let's go get an x-ray. Took me back. She was like, we came in, you really did break your foot. I'm like, yeah, I told you I did. But like
Mhm.
my pain level, like it's bizarre. But I knew I did it because like the shock kind of set in, and the adrenaline and stuff like afterwards, like I'm like, and everything just started to shake. You know, it's weird, but it's just pain tolerance. Yeah.
No, same thing happened to me. When I tore my ACL, completely tore it, I kept dancing. They couldn't believe that I had like completely tore it because like I mean, I felt uneasy.
I don't want to. What are we doing?
And yeah, like my sorority thing, like my mind things I was out with, they couldn't believe the next day when I said, yeah, we got it.
I thought it broke right again.
Everybody thinks, well, here's the thing figured out. Okay, and there are patterns.
That's what I'm assuming this is from.
And so, yes, fibromyalgia can be its own entity, or it can be in conjunction with some of these other rheumatologic diseases. But what they think is that the something happened early on during childhood development that was extremely traumatic to these patients. And people have a way of repressing their memories. But that pain, at any time they're stressed or other noxious stimuli or high levels of stress, it gets abnormal processing in the brain, and that it is experienced as diffuse pain. Okay, so the definition is widespread pain. It's non-articular. It does not involve the joints. Yes, there tend to be trigger points or specific areas in the muscles, myofascial pain. There's also sleep disturbances that lead to difficulty concentrating. So they call it fibro fog. But you know what it's like when you don't sleep. Can you think straight? No. Can you sleep well when you have a lot of pain? No. So it's this vicious cycle for these people. But most of the time, fibromyalgia is actually a diagnosis of exclusion. Okay? You have to rule out hypothyroidism, lupus, rheumatoid arthritis. You know, you've got to rule out some of these other disease processes, sometimes cancers, lymphomas. You got to rule them out because these patients, anemia, they're so fatigued, they're so miserable. Sorry, all this talking and lots of pollen. So definitely happens more so in female sex, female gender. There may be some genetic predisposition. There's often some kind of trauma or abuse that occurred during early childhood, during development, brain development, that has affected these patients' pain processing. And then they get under this kind of persistent stress or distress. And anything that actually, you know, stresses them more, just continues to drive this process. And so not being able to sleep, feeling pain, not being able to walk, not being able to show up for work, having financial stress, losing your job, relationship difficulties, all of these things tend to snowball on these patients. Okay, the pain itself is maladaptive stress response. It involves the hypothalamus, the pituitary, your adrenal cortical axis, so your stress hormones. How many people have seen somebody who has fibromyalgia? Anybody? What's their body have to slice the leg? They tend to look like hypothyroidism. So they tend to be a little bit overweight. You know, they tend to be very slow, very sluggish, lethargic. And yeah, exactly. So again, cortisol, excess cortisol level, your stress hormones. Right? They often will develop type 2 diabetes. Throw in your negative emotions. Again, they become stressors within. And when these negative stressors dominate, it's this whole ongoing kind of self-perpetuating syndrome. So the best thing we can do, we often use, and I don't know what you were taught in ClinMed, but typically it's a combination of like cognitive behavioral therapy, physical activity, and often antidepressants or some type of mood stabilizer. TCAs we often use, and so it's a lot of, it's combined therapy. Now, you're not gonna get these patients out on a treadmill or a track and have them, go around the track. What works great for them is aquatic therapy, especially in a warm pool. So aquatic therapy works because number one, it's warm, relaxes the muscles, the muscle tension. The buoyancy effect can significantly help. Okay, joint pains, etc. And then you can actually have them do some exercises, start getting moving, build up your own natural endorphins to fight the pain. These patients often will feel better if they can get into a regular form of exercise because of it being a stress reliever, etc. But it's a multifactorial approach. And it's not autoimmune. You're not gonna find any labs that are gonna support it. It's not like you're going to have T-cell inflammation and all this kind of stuff. It's not. It's central processing of pain. And it's just, maladaptive stress response. Fascinating, really. But the pain is real, okay? I will tell you that their pain is very real. And that's one of the first things you have to acknowledge, that their pain is real. You believe them, you've got to establish that relationship. Because this is a process, getting to this, ruling out all these other things to say that, okay, you have fibromyalgia. Now I need you to trust me. This is how we're going to approach it. Okay. And so, yes, there are some pro-inflammatory cytokines because of the activation of your HPA axis and those stress hormones. Okay, and yes, you're gonna have some, it does involve all these different, pain modulators within our nervous system and the spinal cord. Okay, this just shows you kind of the different trigger point areas. Again, diffuse widespread pain, it involves, it's myofascial as opposed to joint. Questions on fibromyalgia?
It didn't advance.
Did I? Yeah. I did. Back, there you go. Boom. Shut in. I'm gonna use this today. So, and this just kind of shows you. All right. Last one is chronic fatigue syndrome, and that's it. Then we're done for the day, okay? Chronic fatigue. There's a lot of crossover with chronic fatigue syndrome and fibromyalgia. Okay. Do you have fatigue with fibromyalgia? Yep. Do you have fiber fog, fibromyalgia, and yes. So there's a lot of crossover with fibromyalgia. What's the main complaint? Pain, widespread pain. All the other stuff is additive, but the main complaint is pain. With chronic fatigue, okay, the main complaint is fatigue. Okay, yeah, and confusion, inability to concentrate that goes with fatigue. Think about yourselves after you pulled an all-nighter studying for an exam, okay? Right? So,
You guys pull on later.
we don't know specifically what the current thought process is, that the immune system from some type of infection has not quite reached that resolution phase. Okay? And And so they seem to think that chronic fatigue syndrome does have an infectious etiology. Anybody here had infectious mono before? Yes. How tired were you? Okay. EBV is one of the biggest, and EBV stays with us, okay? It stays with us, it hides out. So EBV is one of the biggest known culprits of chronic fatigue syndrome. What's the other virus that creates an EBV, a mono-like syndrome? CMV, okay? Both of these are implicated. Okay, both are relatively common. And so by definition, chronic fatigue says, okay, it's a state of chronic fatigue present for 6 months or more, no clear cause. So you've got to rule out hypothyroid, you've got to rule out anemia, you've got to rule out some of these other pathologies, cancer, okay? And it has cognitive difficulties, well, no sleep, poor thinking, okay, makes sense. So essentially what you gotta consider it to be is this kind of infection with this immunologic manifestation. And you know, when you get sick and you have this immune reaction, how it tires your body out and all you wanna do is sleep. Well, it just goes unchecked, unregulated, and it persists for 6 months or more, even though whatever the virus or infection was, has already kind of resolved itself. Your immune system is still working overtime, resulting in this fatigue and not being able to sleep. Okay, so it's an upregulation of your immune system. And there can be increased levels of multiple antibodies, depending on maybe what the trigger is. It could be an IgG to Epstein-Barr. It can be an IgG to Coxsackie virus B. It can be human herpes virus 6, chlamydia pneumoniae. What we do see overall is a depletion in the total number of natural killer cells, your NK cells, NK lymphocytes, okay, which goes along with viral infections. Okay, that's how our body rids of a lot of these viruses, is through these NK cells. So, you know, that's really kind of the evolving paradigm right now for chronic fatigue. Any questions?